I'm Gilles Salle from Memorial Sloan Kettering. It's my pleasure to co-chair this session with my distinguished colleague and friend, Dr. Laurie Sen from BC Cancer in Vancouver, Canada. I think we'll have an exciting session with several presentations regarding aggressive B-cell lymphoma. Some of the talks will be followed by questions. Others, unfortunately, won't because of the length of the talk. But without further delay, let's see what will be coming in the first talks. And I think the first presenter will be Dr. Georg Lenz, who will discuss the dissection of the biology of Dlbcl and how close are we from a molecular validated molecular platform. I think you all know Dr. Lenz from Münster, Germany, who had made a seminal work several years ago regarding the biology of Dlbcl. So let's hear his talk. Thank you.
Dear colleagues, first of all, I would like to thank the organizers for this invitation to give this presentation at the SOHO meeting. This is a great honor. Thank you very much. So my name is Georg Lenz, and I'm the director of the Department of Hematology and Oncology at the University Hospital in Münster. Today, I will be talking about dissecting the biology of Dlbcl. How close are we to a clinically validated molecular platform? This is obviously, at least for me, a very challenging topic, especially in 15 minutes. So therefore, I decided to really focus on identifying reliably and reproducibly of Dlbcl subtypes that were defined by their gene expression profile and also just recently by their mutational signatures. So these are my potential conflict of interests. They will obviously not influence the content of this presentation in any way. So as you're all aware, diffuse large B-cell lymphoma, which represents the most frequent lymphoma subtype, is a heterogeneous diagnostic category. This heterogeneity affects different aspects of the disease. This affects the pathologic, the morphologic diagnosis, as we can reliably distinguish certain morphologic variants, and this is an incomplete listing. It influences the clinical manifestation, as there are certain subtypes that occur at specific sites. Again, this is an incomplete listing here on this slide. And finally, with respect to heterogeneity, and this is the most important part for the patient, there's heterogeneous response to our conventional treatment. As you all know, for the vast majority of patients, we apply a combination of the anti-CD20 antibody rituximab and the CHOP chemotherapy. And by doing so, we can cure, depending on your subgroup of patients, roughly 65, maybe 70% of our patients. Again, there's heterogeneity because you cannot cure everybody, and not everybody dies of their disease. So we have a striking heterogeneous diagnostic category. So significant improvement to understand this heterogeneity was made already 20 years ago by Asher-Lizaday and Lou Stout when they applied gene expression profiling to primary biopsies of diffuse large B-cell lymphoma patients, and they identified, and this was reproduced by many different groups, certain specific molecular subtypes which were termed ABC, activated B-cell-like diffuse large B-cell lymphoma subtype. This is a subtype that is characterized by a gene expression profile of an activated B-cell. Then the second large subtype, the so-called GCBs or germinal center B-cell-like Dlbcls, as the name implies. This is a subtype characterized by a gene expression profile of a germinal center B-cell. And then there are other subtypes, such as the primary mediastinal B-cell lymphomas, that also have a specific gene expression signatures. And then we have approximately 15 to 20% of primary patient samples that we cannot classify into these subgroups, which were called unclassifiable Dlbcls. Why is that clinically important? We all know that ABCs, when we focus on ABC and GCB now, that ABCs have a significantly inferior survival compared to GCB patients when we treat these patients both with R-CHOP, and you can see that on this slide, and this has been reproduced in the meantime many times. This is true for both progression-free and obviously more importantly for overall survival. In addition, besides having a different gene expression profiling, and having different mutations and different overall survival, these subtypes are addicted to different oncogenic pathways, as has been shown by many different groups. And this is important when we specifically think about adding novel substances. So in the beginning, it was very challenging to identify these subtypes because gene expression profiling using Affymetric chips or other platforms required fresh frozen material. However, in the meantime, we have reliable molecular platforms that can use to make the diagnosis of ABC, GCB, or unclassifiable Dlbcl. And this was first shown, as shown over here, by David Scott and published in Blood, that you can use the nanostring platform and the Lymph2CX assay to identify ABCs and GCB. In the meantime, and this has been very nicely summarized by a recent paper by Ahmed and colleagues and published in the British Journal of Hematology, that you can use different platforms to reliably classify ABC, GCB, and unclassifiable Dlbcl. And you can use the Dlvcl platform, you can use RNA-seq, you can use Affymetric chips, or you can use the ATG platform. So I would summarize this part. So ABC, GCB, unclassifiable Dlbcl can now really be reliably identified, diagnosed by different platforms. So has the ABC, GCB, Dlbcl classification changed therapy? Unfortunately, no, despite the fact that we performed clinical trials within this setting. And I just want to show you one example that actually used the nanostring platform to identify ABC patients. And this was the Robust trial that was first presented by Umberto Vitolo and in the meantime published by Greg Nowakowski and colleagues in JCO. So the Robust trial tested the efficacy of lenalidomide in the frontline treatment of ABC Dlbcl patients, and was a randomized phase 3 trial that compared R-CHOP plus lenalidomide compared to R-CHOP plus placebo. And this is the study design. And as you can see over here, to perform such a study in a subgroup, you have to screen a lot of patients. More than 2,000 patients were screened within this trial. And these are the results. No improvement of progression-free and, more importantly, overall survival by adding lenalidomide. So this finding and the finding of other trials that also did not show an improvement for specific subsets of Dlbcl patients led to the notion, what we saw before in the laboratory, that obviously ABC-GCB distinction is a good distinction, but still that heterogeneity prevails within ABC and GCB. And subsequent analyses have identified subtypes within ABC and GCB. So first, a very nice study was published by Reddy and colleagues that really defined the mutational landscape of Dlbcl. More than 1,000 primary Dlbcl cases were sequenced by whole exome sequencing within this study. And as I said, the mutational landscape was defined. A very similar approach was taken by Schmitz and colleagues and Lou Stout. And again, several hundred primary Dlbcl patients were sequenced within this trial. And so within this trial, novel subtypes within ABC and GCB were identified. So based on their mutational landscape, 4 different subtypes were identified. First, the so-called MCD subtype that is enriched for ABC Dlbcls, and that is characterized, among others, by the co-occurrence of CD79B and MYD88 mutations. The second subtype, the N1 subtype, again enriched for ABC Dlbcls, is characterized, again, among others, by Notch1 aberrations. And then the EZB subtype that is enriched for GCBs, as you can see, that is characterized by EZH2 mutations and BCL2 translocations. And then finally, the BN2 subtype that encompasses different Dlbcl subtypes and that is characterized by Notch2 and BCL6 aberrations. However, when you look at these subtypes and you look at the overall landscape of Dlbcl, you can see that roughly 50% of all Dlbcls can be classified into these 4 subtypes. Interestingly, there are survival differences, again, when you use R-CHOP as treatment, as you can see on this slide. follow-up work by George Wright and again Lou Stout identified 2 novel subtypes in addition to the just 4 mentioned subtypes. This is the ST2 subtype that is enriched for GCB Dlbcl samples, and that is characterized by SJK1 mutations and TET2 aberrations, and the A53 subtype that is characterized by P53 mutations and deletions, among others. And this is very nicely summarized. So when we get a more precise look at ABC GCB, very nice summarized in this Cancer Cell paper, you see the prevalence, the overall survival, and the addictions to specific pathways and potential therapeutic targets. A very similar approach was taken and also published in 2018 by Bjorn Chapuis and Margaret Shipp. They sequenced and analyzed by additional techniques more than 300 primary Dlbcl samples. This is the mutational landscape that they detected. And within this mutational landscape, they detected 5 recurrent clusters of Dlbcls. And I don't have time to go into the details. There is also a lot of similarities to the Lou Stout analysis. They found with these subtypes and the 5 clusters. And again, there were survival differences within these subtypes. As you can see that within GCB and also ABC, we can now identify subgroups that have a better or a worse outcome. So the question now arises, can we identify these subtypes in the clinic, in clinical trials? Is there a molecular platform available doing that? To my knowledge, the answer is no, at this stage at least. I think it's rather complicated to identify these subtypes, and you need to have a lot of knowledge. Therefore, it's not ready for prime time. However, and I want to give you one example, I think we can utilize these novel subtypes already in clinical trials, because that has been shown in a very nice study, and this has been presented at the just recently completed Lugano meeting in June, in a Chinese study that has been presented by Zhang and colleagues. Within this trial, they asked the question, can we improve R-CHOP by adding specific substances when, after the definition or the classification of a patient to a certain Dlbcl subtype? So this is the study design. As you can see over here, Page had to have an IPI of greater than 2 or 2 or greater and an age of 18 to 80 years of age. They were included in the trial and treated with R-CHOP. In the meantime, the molecular analysis was performed, and after that, patients were randomized either to R-CHOP or R-CHOP plus X. And X was, in this case, for the MCD and the BN2 subtype ibrutinib, for the N1 subtype lenalidomide, for the EZB subtype tutsidinostat, which is an HDAC inhibitor, for the TP53 mutated decitabine, and for others, lenalidomide. So this is the study design. The primary endpoint was the CR rate, the secondary endpoint, PFS, overall survival, overall response rate, and safety. And this was the consort diagram. In total, this is a fully recruited trial. 128 patients were randomized, and 64 patients were treated in the R-CHOP in the standard arm, and 64 patients in the R-CHOP plus X arm. This is the pathologic criteria with the GCB, non-GCB, and the certain molecular subtypes that have been identified. And these are the results. So there was a significant improvement of the primary endpoint, this complete remission rate, as you can see over here on the left side. And there was a significant improvement of progression-free survival for the R-CHOP plus X arm. When you look at the subgroups, obviously you have to, in general, you have to be very cautious with a small trial, but here the numbers are extremely small, but you see, or you have the impression that there's an improvement within these different subgroups. So I think this is a very nice, that you very nicely can see that you can already utilize this knowledge into clinical trials and perform these analyses in clinical trials, despite the fact that we don't have a platform available for the clinical routine at this stage. So with that, I want to conclude. I hope that I was able to convince you that diffuse large B-cell lymphoma is a heterogeneous diagnostic category. We have various novel subtypes that have been identified beyond ABC and GCB. For ABC and GCB, I think it's really clear that we have established validated platforms for the diagnosis. For the novel subtypes of both Lou Stout's group and Margaret Shipp's group, I think we're not there yet, and this is warranted. However, we can utilize these novel subtypes already when performing clinical trials. With that, I want to thank you for the attention. Thank you very much.
Thank you. This was really a wonderful talk, as we expected, by Dr. Lenz. Unfortunately, he couldn't join us for the Q&A session, so we will immediately move on to the next talk. We will be presented by Dr. Jason Westin from MD Anderson, Texas. And Dr. Westin will discuss the innovative approaches that can be envisioned in the frontline setting of treatment of patients with Dlbcl. My understanding is that this talk will be a little bit prolonged also, and that we won't take questions at the end. Sorry for our colleague, but we look really forward to hear his thoughts about how we could move forward and what are the lessons we have taken from the trial he conducted and the ones that are ongoing. So, Dr. Westin.
Hello, SOHO. My name is Dr. Jason Westin from MD Anderson, where I'm the section chief for aggressive lymphomas and the director of clinical research. And it's my pleasure today to talk to you about innovative approaches in untreated Dlbcl. These are my disclosures. So we're talking today about large cell lymphoma, and this audience knows well that R-CHOP is the standard therapy. It's been there for quite a long time. Originally, CHOP described in 1976 in a paper from, in part from MD Anderson, showing the same doses we use today. Rituxan added approximately 20 years ago, and it benefits the vast majority of patients. And the slide on the screen here from Professor Sahls and Professor Sen shows that it's really a good therapy for the vast majority. However, it's the treatment-resistant disease, that initial group, that we need to focus our efforts on. How do we improve that initial drop of the curve and not add additional toxicity for those that are currently doing well? And often that's looked at by adding something to overcome resistance, the so-called plus X approach, the adding an additional therapy that can help overcome or target that resistance. Advantages of plus X trials, which are of course done across the oncology spectrum, are myriad. They're easy to do, both statistically. It's a null versus an alternative hypothesis. It's kind of binary. It's mentally easy. You're changing one variable, so it doesn't require a lot of mental energy to think about how that could potentially be better or why it may be better. Financially, it's easy in the sense that it has a large population size, so maximal benefit both for our patients as well as for the sponsors of these trials. Regulatory-wise, the FDA has plenty of precedent of approving an incremental change to therapy. It's also scalable. It works at the ivory tower in the academic center as well as in a rural or an international practice. So there's plenty of advantages of the plus X approach. But before going there, can we actually improve upon CHOP itself? That's sort of a no-brainer. Let's go back to 1976 and see if we can't do any better here in 2021 or beyond. And unfortunately, we can't based upon these trials. Looking at the schedule, our CHOP every 21 days versus every 14, no improvement. Looking at the addition of a topicide or changing the regimen to an infusional regimen, the R-CHOEP or R-EPOC unfortunately did not show a significant benefit. The RACVVP trial did show an improvement in young, low-risk disease. However, the reason why we're not talking about ACVVP as a standard therapy is it's crazy hard to administer. It's Q2-week chemotherapy for 30 weeks. And it includes some therapies that sound a lot like a transplant to me. Ifosfamide, etoposide, cytarabine, methotrexate. It is a heavy-duty therapy for a benefit which is statistically significant, but logistically very hard in a group that typically does well, the young, low-risk patient population at baseline. Similar, transplant was looked at and showed to benefit folks in the PFS sense. However, we're giving a lot of people a transplant who are likely already cured of their large cell lymphoma. And if we look at the overall survival, those that did not respond to transplant were able to cross over and effectively get a transplant in a relapse setting, having no difference in overall survival. So this is also not something we do. And what I'd conclude is that R-CHOP, or all the different iterations of R-CHOP, show that large cell lymphoma is chemosensitive except when it isn't. there's a diminishing returns component to additional therapy. So back to the idea of how to do better than CHOP, let's target the aberrant biology with plus X. We obviously know a ton about the biology, more so than we did in the 1970s. And these two figures here are not meant to go through in detail, but are examples from the Stout lab and the Ship lab of all the beautiful, elegant biology we know about what makes large cell lymphoma a common cancer. It's got lots of different abnormalities that under the microscope look the same, but under genomic profiling can be called out. Why not target these abnormalities with plus X approach? And of course, this is what's been done in many large phase 3 trials. So why hasn't it worked? It seems so obvious. Let's just improve and target the resistance. And I would argue that R-CHOP has largely been a spectacular failure when we do the plus X approach. R-CHOP plus X has been a failure. Many studies with thousands of patients have been done. I think, in my opinion, it's a lazy vehicle for incremental gains, huge time, money, and patient investment to further cement 1970s chemotherapy deep into 2021. And I think this is a conclusion I've shared before, and I'll share that's probably already happened at this point by the time we're talking at SOHO. We will see a plus X trial succeed, but the product that comes from that will be modestly better. It will cost much more, and most patients will do about the same. And that's as evidenced by Exhibit plus X. All of these good drugs on the left-hand side have gone through the plus X graveyard and effectively have been damaged by this trial design despite having activity in large cell lymphoma. Those on the left-hand side are still ongoing, and of course, we wish them the best. We hope that these trials are spectacular successes, but they're running the same risk of the trials that came before. The asterisk here is Pembrolizumab. We know the Polaris trial has recently had a press release here in the fall of 2021 suggesting that the PFS is better. We don't know yet the magnitude of that, and if that will be an earthquake or a tremor, still to be determined. Basically, my underlying argument here is that plus X is not targeting CHOP resistance. It's not going at that initial drop of the curve in a way that seems logical to overcome the failures of R-CHOP. And unfortunately, we're not really able to well predict who those patients who are failed by R-CHOP are. We have prognostic tools, but they're not predictive. We have the IPI, we have double hit and or potentially double expressor. We have the interim PET, which is of course very controversial, but for those that have a positive PET, you know that outcomes generally are potentially inferior. Definitely with a lot of controversy on that. ctDNA without a 2-log reduction, as described by Drs. Kurtz and Elizadeh, I think potentially could be a more predictive marker, but still not widely available and not something that we've incorporated into clinical practice. Unfortunately, we don't understand why these 1/3 of patients aren't cured. Plus X hits a large cell relevant target, but is the activity orthogonal to R-CHOP activity, or is it overlapping? Are R-CHOP responders also plus X responders? Or is there a different part of the Venn diagram where R-CHOP resistance is responding to plus X? Plus X agents are not aimed at chemotherapy resistance mechanisms specifically. They're aimed at targets that might actually be modulated by R-CHOP itself. So first principles, you want to understand the problem by what's driving it and what you're doing to it is what the perturbation of the system is actually doing, how the drug works. Many people think we do this all the time. I don't think we do. I think my thesis is we don't harmonize these on a patient level, but we could. And unfortunately, here in 2021, the bench-to-bedside loop is broken. We've got a bench-to-bedside, but not the inverse. We're not sending the information back to our translational colleagues. And that's evidenced by how we choose plus X. We have a very reductionist approach where we know a mutation or a pathway is abnormal, so I'm going to target it. An example here would be BTK is important for BCR signaling. BCR signaling is critically important for the ABC subtype of large cell lymphoma. Therefore, BTK inhibitors should work great in ABC large cell lymphoma. And that's, we know, true that there are responses in the relapse, but the Phoenix trial suggested that adding that to plus X in that same population didn't work. So what are we not considering? We're not considering what CHOP does to that pathway, what the alternative pathways are how they're impacted by CHOP or X or CHOP plus X, and what are the consequences of the multiple other kinases that are inhibited by plus X. Back to the ibrutinib story, we know that so-called dirty drugs hit lots and lots of pathways. Are those completely irrelevant, or is it possible we're modulating things in a way that we don't quite understand? And then again, one more time, the point is CHOP parallel or orthogonal to X. We don't know. We don't have an answer to that. And that's a failure on our part to better understand what we're doing in the preclinical space before taking that to the clinic. So can we do better than plus X now? Well, I'm giving this talk today because I think that we certainly can. And as evidenced by my SMART START trial using Rituxan and lenibrutinib prior to chemotherapy in non-GCB large cell lymphoma, we saw a response rate of 86% prior to a drop of chemo and effectively 100% response rate at the end of all therapy in a high-risk group of patients. My SMART STOP trial, which is likely to launch any day now when the lawyers can agree where the commas need to go in the 55th page of the contract. I'm not bitter, but will open any day now. Uses a large combination of lenalidomide, tafasitamab, rituximab, acalabrutinib for 4 cycles prior to giving a response-adapted number of cycles of chemotherapy. Initially 2 cycles in responders, and if that's successful, potentially even no chemotherapy in those who are achieving a complete response. We don't know yet the results, obviously, because the trial's getting ready to launch, but these kind of response-adapted approaches, I think, are really important for us to better understand which patient, which therapy. So I would argue going forward, we should look at studies which are able to scale better than my SMART START and SMART STOP trials, building upon this idea that we can do better, not stuck in the 1970s plus X, using response-adapted approaches. But I would argue that we need to incorporate ctDNA very heavily in how we determine responses. A better way, I think, in addition to what I've just described, this is sort of the long-term next steps that my group at MD Anderson are trying to explore in the preclinical space. The top half of this curve is what we do right now. We get a biopsy for diagnosis. We then give an empiric chemotherapy, and patients go into the black box, and on the other end, they're either cured or they're not. I think we should be using more of that biopsy, not just for initial diagnosis and empiric chemotherapy selection, but to better understand the drivers of that disease for that given patient and what the therapy actually does in that disease. And I think the patient-derived xenograft or PDX model is a great way for us to do that, not for a given patient. It's not able to be turned around in that rapid of a time frame, but as a way to us building libraries in silico to better understand what the disease looks like in terms of therapies, not in terms of genomic classifiers, which may not be applicable to a given therapy. And so what does this look like? I just showed we do the biopsy, we give the chemo, we don't understand what happens, magic or not. Instead, doing the biopsy, generating the same tumor in a given mouse, growing this up to dozens, if not hundreds, of different versions of the same tumor through different generations of patient-derived xenografts, and then conducting effectively a clinical trial in the same tumor, giving multiple different therapies head-to-head within one tumor as opposed to one therapy for multiple different tumors. Different chemos, and this is done largely by my colleague, Dr. Michael Green. I'm by no means an expert on how to do these things, but do think of the concepts and partner with my colleagues who are able to actually do the science. Different chemotherapies, different targeted therapies, and we pick winners to effectively do a type of design called a king of the hill, enriching for winners either for a local optimum or an overall optimum therapy for a given subtype of large cell lymphoma. And what this allows us to do is therefore on the back end, figure out the response to therapy over a large group of patient-derived xenografts. And this is a mock-up of fake data, but basically you can imagine responses clustering in ways where you could effectively derive a group of xenografts which have similar responses to a given therapy, and then figure out what these groups look like in a reverse engineering way to how they could apply in a CLIA setting to the lab. It's fish testing for the known markers, BCL2, BCL6, MYC. Is this protein expression? Is this previously described mutations? Better understanding it's not based on what we think is the biology, but what is the response to therapy, which is ultimately what matters to our patients. And then this would allow us for the next patient that comes through clinic to have the ability to do a biopsy, and instead of just giving them empiric chemotherapy until they're cured or they're not, you then could potentially give one cycle of a probe therapy, and if they don't respond to that, then you go on and switch to the therapy that you've got a higher probability for enrichment based upon your data. So why do we need a response phenotype? An example, I'm going to do some mock-up data here. Give me a moment to get you the conclusion about some math of a hypothetical. We have an amazing new drug called Curvimib, which has a 100% complete response rate in a rare subtype R of a fictitious cancer that I'm not describing in any way, Dlbcl. This subtype's 1/5 of patients, 20%, and unfortunately only a third are cured with initial therapy. The other, subtype L, 80% of initial therapy, initial disease, is cured 2/3. So we in frontline cure 3 out of 5 patients, 60% are cured with standard therapy, only 1 out of 3 with this subtype R. So if we look at 100 patients, the blue represents the rare subtype, and we only are curing 1/3 of that. We're curing 2/3 of the more common subtype up above, and this will shift the dynamic in a relapse population for what the disease biology looks like. instead of being a 4-to-1 subtype L versus subtype R, now we have a 2-to-1 of subtype L, subtype R. And a lot of our trials for initial drug development are done in this relapse space, where a lot of our discovery work is done in the frontline biopsy space. So perhaps over or underestimating disease subtypes that could be relevant for therapy. All right, well, it's relapse disease. We now do a clinical trial of this drug, Dlbcl, and we have the patients who were not cured by frontline therapy, now a 2-to-1 of subtype L versus subtype R. And in this grouping of patients, we see 100% response rate in subtype R and a pretty crummy response rate, 11% in subtype L, but overall it's a CR of 40%. Again, we don't know what subtype R and subtype L are. We're not smart enough to understand that. We just see a 40% response rate in relapse disease. 40%, hey, that sounds like that could be approved by the FDA. And so Dlbcl is amazing. It's a breakthrough designation. Stock price goes through the roof. It's in the New England Journal and the PIs on the lecture circuit. 18 abstracts presented at all the big meetings. Very smart doctors advise confirmatory frontline randomized trials. And we've got staff to design a 500-patient trial, which we then do 1-to-1 randomization. Again, the distribution of these subtypes is different in frontline than in relapse, but we don't know that because we're not smart enough to know what subtype R actually is. And we see in the standard of care, as expected, we've got a CR rate of 67% in the dominant group, 33% in the R group, overall 60%. When we do the plus X group, we see a CR rate of 75% in this rarer group. However, the toxicity or activation of alternate pathways, we lose some ground in the subtype L. CR is only 57% here. And so at the end of the day, the trial shows an overall complete response rate of 60% versus 61%. It's a negative trial. How the hell could that happen? We had a 40% response rate in the relapse, and the frontline didn't work. This is how, is we don't understand which patients, which therapy, because we don't have the therapy as a pro disease biology. So the conclusion of that trial, Dlbcl is terrible. FDA pulls the approval. The stock price drops. The PI has to explain their failure. 3 abstracts are posters, and very smart doctors concluded we needed more patients. We needed the biopsy required meant we excluded the sickest, and the relapse trial was a unicorn patient population, not real life. That may not be the answer that we're looking for when we actually know why of the different subtypes. So in alternate reality 1, COVID vaccination is nearing 100%. Data-driven technocrats are completing real-world experiments to pick the optimal healthcare systems. Teachers are paid well. Carbon neutral energy generates 100% of our needs, and clinical trials are done optimally. Here we have 150 patients with subtype R, and we do a 1-to-1 randomization of standard of care plus standard of care versus X versus standard of care plus X. And because we know the data are going to be so good from our initial experiences, we actually cut that number in half and only look at 25 patients per group. And we say we're only going to open the standard of care plus X arm if we miss our futility on the first batch of patients. And so we enroll 25 patients per group, and Dlbcl kicks the butt of standard of care. We have a CR rate of 33% standard of care and 96% in the frontline setting for plus X alone without chemotherapy. And this drug is now approved. So you compare the two options. The first option of the unspecified group, 500 patients, $100 million, Dlbcl withers on the vine. The second, where you now know the therapy-based classifier, 50 patients, $10 million, and Dlbcl cures them. So we need to design trials where the stats are almost irrelevant because the results are so good. So you say this is a fantasy, Weston. You're kind of doing some scenarios which have no applicability to real life. I'd say you're wrong. This actually has already happened. This is in lung cancer, the drug gefitinib, that in 2003 was approved based on early results in relapse trials. Additional studies showed that it didn't work, and they pulled the approval only for patients who could still get the drug, were already benefiting from the drug. And then when we figured out that EGFR was the relevant mutation, it's now part of standard therapy. It's back on the market, and there's lots of other EGFR inhibitors. So in conclusion, of a better than plus X now and for the future, we need to do better on our classifiers using both genomics and drug sensitivity. And I argue that the PDX would allow us to have an in silico model where new patients can be assigned to their response to targeted therapies, not guessing based upon biology not tethered to the therapy. Utilize better learning technologies such as machine learning and AI to better find these subtypes, better response technology, ctDNA, or more innovative PET analyses, And lastly, designing smarter clinical trials to study the right drug in the smallest number of the right patients based on response phenotypes. And I'll thank you for your attention.
Thank you, Dr. Westin. This was wonderful and a claim to move forward. I think we have time for one question and a rapid answer, but let me ask you, if you had to prioritize right now, based on what we know, and not what we will learn from the lab of Dr. Green in 3 years, 5 years, or hopefully tomorrow, but just right now, will you put your eggs somewhere particular in a given particular subset of Dlbcl with a particular agent?
I think it's a good question. What do we do in the meantime while we're trying to get the science? Unfortunately, I really don't think we've cracked that nut. I think the cell of origin is better than nothing, but it's failed on multiple trials. Double hit, of course, is a big unmet need. But I think the future is going to be better tomorrow, as Dan Quayle said, and we need to keep doing the research so that we can get there. Not ready for prime time just quite yet.
So thank you. That's a modest question, a modest answer, unrealistic. But I think you keep us thinking forward. So our next speaker is our co-chair, Dr. Laurie Sen, and she will discuss with us the progress that we have made in the relapse refractory setting with, I think, essentially approved agent in this setting. And we are eager to discover what has been brought for patients in recent months or years.
My name is Laurie Sen. I'm from BC Cancer in Vancouver, Canada. And today I'll be talking about sequencing therapies in transplant ineligible patients with diffuse large B-cell lymphoma. These are my disclosures. So we know that patients with diffuse large B-cell lymphoma can be cured with frontline R-CHOP. However, not everyone can be cured. Approximately 30 to 40% of patients will either prove to have primary refractory disease or ultimately relapse. And the majority of these will do so early, within 2 years of therapy, and definitely exhibit chemotherapy insensitivity. So the management of relapse refractory Dlbcl is changing, and the options are growing, and really best management should consider the goal of therapy. So historically, the goal would be to try and come in with next line therapy that would give the patient the best chance of secondary cure. This has relied largely on salvage therapy, as well as high-dose chemotherapy and stem cell transplant. However, not everybody is eligible for this approach due to age and comorbidities. More recently, the availability of CAR T-cell therapy has also proven to be an effective therapy for patients who are not potentially transplant eligible or relapse after transplant, showing durable disease control and possibly cure in a proportion of patients. We'll be seeing data emerge shortly that will compare CAR T-cell therapy with stem cell transplant, and we wait to see that data presented in full, as we may see that CAR T-cell therapy may move forward in the management strategy of these patients. But historically, we did rely on chemotherapy largely, which we know had limited benefit in these patients with chemotherapy insensitive disease. Palliative radiation is only for focal management, and the majority of these patients have systemic disease, so not very applicable. And similarly, allogeneic transplant, rarely an option for these older patients. So it's exciting to see that more recently there have been the development of novel agents that have increased the number of therapeutic options for these patients. So of course, we know that CAR T-cell therapy has been a game changer for these patients, that in the pivotal trials that we saw published already, a proportion of patients seem to achieve durable long-term disease control. However, CAR T-cell therapy will not be appropriate for all patients due to unique toxicities, including cytokine release syndrome and neurotoxicity. And of course, not all patients are cured by CAR T-cell therapy, so it leaves definitely a great need for novel agents. And more recently, we have seen the emergence of novel agents that are now allowing us to obtain durable disease control for our patients. So the first drug that received approval in the relapse refractory Dlbcl setting was polatuzumab vedotin. This is an anti-CD79B drug conjugate targeting CD79B, which is present on virtually all patients with diffuse large B-cell lymphoma. And when internalized, it releases an MMAE toxin that leads to microtubule disruption and apoptosis. So the GO29365 study was the trial that earned this drug FDA approval. There was an initial safety run-in, followed by a randomized phase 2 portion, and then an extension cohort, which was more recently presented. So in this study, the polatuzumab vedotin was combined with bendamustine and rituximab, which is commonly used to treat lymphomas. And it essentially was added on day 1 of each cycle of BR with up to 6 cycles of planned therapy. So this was a finite regimen. In the initial presentation of the randomized phase 2 portion, where pola-BR was compared with BR alone, we saw that it met its primary endpoint of a significant improvement in complete response rate, which importantly translated to improved progression-free survival and overall survival. That data was initially based on 40 patients in the randomized pola-BR arm with a follow-up time of about 22 months. We now have more data available on this combination from an extension cohort, and this data was recently presented at ASH of 2020 and included 152 patients now who have received pola-BR. The patient characteristics of this pooled cohort are listed here. And you can see that the median number of prior lines of therapy was 2, but the majority of these patients were highly refractory, having been either primary refractory in just over 60% of the cases, and over 75% of cases were refractory to their last therapy. This slide demonstrates the best overall response rate exhibited, and you can see that patients who had received only 2 prior lines of therapy, those with non-refractory disease, actually fared better. If we look at patients with non-primary refractory disease, the best overall response rate was 90%. I think what's intriguing with this data is that of those patients who respond, the responses are actually quite deep, with the majority of responses actually being complete responses. On the left here, you see the progression-free and overall survival curves of the randomized cohort that had initially been presented, now with 4 years of follow-up. And we can see that the survival benefit compared to BR alone has been sustained over time. And there does appear to be a tail on this curve with a 2-year progression-free survival was 28% and 2-year overall survival 38%. In the extension cohort where the follow-up isn't as long yet, these curves are looking very similar. And we can tell that patients, for example, depending on their refractory status, the non-primary refractory patients actually had a median progression-free survival of 13 months and a median overall survival of 32 months. This slide demonstrates the safety summary in the pooled pola-BR cohort. We can see that the primary toxicities relate to cytopenias and including neutropenia with some infection seen. In terms of peripheral neuropathy, which can be seen with microtubule disrupting agents, this was generally low grade and reversible. And importantly, with the longer follow-up and the greater number of patients, no new safety signals have emerged. Next drug to receive FDA approval was Selenexor, which is an XPO1 inhibitor. This drug blocks transport of tumor suppressors out of the nucleus, ultimately leading to apoptosis. It is an oral drug administered twice weekly, and in the phase 2 single-arm study that earned it approval, the trial did enroll patients with relapse refractory diffuse large B-cell lymphoma who were not transplant eligible. They had to have received at least 2 to 5 prior lines of therapy, And there was a bit of a washout window of 60 to 98 days from their last therapy that was required. So it may not have enrolled patients with the most aggressive biology. It is given indefinitely. We can see here that the response rates were somewhat modest. So in the 127 patients treated in this trial, the overall response rate was 28% and the CR rate was 10%, with the median progression-free survival being only 2.6 months. The drug was generally well tolerated, though, with the primary high-grade toxicities being thrombocytopenia. However, low-grade toxicities, including constitutional symptoms, were somewhat problematic, including nausea, fatigue, weight loss. So there will be some supportive care probably necessary to make sure that patients tolerate this drug without impacting their quality of life. More recently, we've seen approval of tafasitamab and lenalidomide. Tafasitamab is an anti-CD19 monoclonal antibody designed to induce antibody-dependent cellular cytotoxicity as well as direct cell death. In this pivotal trial that earned its approval, it was combined with lenalidomide, which is a well-known immunomodulatory agent, and given together, these agents may actually augment their immunotherapy effect. So in the phase 2 Almine study, which was a pivotal trial that earned its approval, patients with relapsed refractory Dlbcl who had received up to 3 prior lines of therapy were eligible. Importantly, this trial initially omitted patients with primary refractory disease, although this was then revised. In this trial, lenalidomide was given its standard dose of 25 milligrams orally from day 1 to 21 on a 28-day cycle, and was given for 1 year's duration. The tafasitamab was an IV drug given weekly for the first 3 months, and then was given twice monthly indefinitely. So this is an indefinite regimen. The trial, as published, included 81 patients with a median of 2 prior lines of therapy, and as noted, only a minority of patients were considered primary refractory, at just 19% of the patients. With this combination, we saw very encouraging activity with an overall response rate of 60% and a CR rate of 43%. And at the time of initial publication, the median progression-free survival was 12.1 months. With longer follow-up, this has actually even improved slightly. This was generally a pretty well-tolerated combination therapy. So here we've got the toxicities listed in the first year where it was given in combination with lenalidomide, and then subsequently after that where it was just tafasitamab alone. And you can see that the majority of toxicities really occur in the first year with the lenalidomide combination and are very similar to what we expect with lenalidomide, including cytopenias and rash. Finally, the last drug that's been recently approved in the relapsed refractory Dlbcl setting is loncastuximab tesirine, which I'll refer to as Lonca. This is an anti-CD19 antibody drug conjugate, where here it's conjugated to a PBD dimer that intercalates with DNA, leading to cross-linking and apoptosis. This drug was tested in the phase 2 single-arm LOTUS-2 trial. It enrolled patients with relapsed refractory Dlbcl who had at least 2 prior lines of therapy. The drug was given as an IV infusion, initially every 3 weeks for up to a year, and then subsequently given every 3 months for up to 3 years, but even indefinitely. The trial enrolled 145 patients, the majority of whom had diffuse large B-cell lymphoma, and the median number of prior lines of therapy were 3, so they were highly pretreated. I would say that the results were quite modest, but encouraging, with an overall response rate of 48%, approximately half of which were complete responses, which was 24% of patients. The median progression-free survival was just over 5 months, and the median overall survival was 9.5 months. Importantly, this drug does target CD19, which is the target for CAR T-cell therapy, and it was noted that a proportion of patients treated on this trial did go on to receive CAR T-cell therapy effectively. In terms of safety, the primary toxicities we're seeing were cytopenias with neutropenia and thrombocytopenia. There was noted to be a transient transaminitis as well that was reversible. So with that, I think it's fair to say that the treatment of relapsed refractory diffuse large B-cell lymphoma continues to remain a challenge, but it's quite exciting that we have a variety of novel agents that have now become available for these patients. What we're seeing is that we've got novel agents that are able to overcome chemotherapy-resistant disease and to achieve durable control in many of these patients. Certainly, these drugs have been tested thus far in independent studies and have not been compared head-to-head. So treatment selection and sequencing at this point will need to rely on clinician judgment. I would say that in my own practice, when I see patients, I think it's very important to consider what the goal of therapy is in these patients. Looking at the benefit of these drugs, we'll need to weigh in what we know about the efficacy from these individual trials and weigh it against the toxicities that each unique drug exhibits. Of course, you'd want to match this with who the patient is, what their age is, what their comorbidities are, what we anticipate the tolerance of these treatments will be in individual patients. Of course, there are a variety of schemas where we've got a range from oral therapy to IV therapy, and both convenience and duration of therapy may factor into patient preferences. I think at this point, sequencing of therapy is not quite clear, but certainly we need to think about what we might be doing in the big picture and making sure that we're not closing any doors for these patients. Ultimately, it would be nice to have predictive markers that will allow us to use these drugs more rationally in individual patients.
Thank you, Dr. Sen, for this wonderful overview. I think we have really a picture in front of us of these new agents and the different results that were published recently. During the last part of your talk, you presented the different characteristics that you would like to take into account to choose one or the other therapy. Well, if somebody had tomorrow a 75-year-old person with some comorbidity preventing a transplant eligibility, how will you choose between these different therapies, assuming that they are all available for you and for this patient?
Well, that is the million-dollar question, isn't it? And I think as clinicians, we're all grappling with how to piece together this information so that we can make decisions in individual patients. I think many of us haven't had the opportunity to use all of these drugs yet. And so I think there's a learning curve that everybody will need to go through. The first question I would ask is, do I have something that will come in and cure this patient is the next line. And you've already said this patient is not a transplant candidate. So I think the next solid information we have on potential curability really is with CAR T-cell therapy. So there's a proportion of patients who aren't eligible for transplant, but they still can go on and get CAR T-cell therapy. And so I would be asking that as the next question. Beyond that, I think all the novel agents, as they haven't been compared head-to-head, are reasonable options. And that's where you need to look closer at comorbidities and toxicities, because we don't know that any option beyond that is curable for these patients. And it may just be a matter of selecting them in sequence. Looking at tolerability is probably a big factor in a 75-year-old patient.
Thank you so much for your answer. And I think you are chairing the second part of this session.
I am. And I have the pleasure to introduce the next speaker, which is my lovely co-chair, Dr. Dlvcl from Memorial Sloan Kettering. And he's going to pick up the concept of where are we going in the management of Dlbcl and discuss really what we're all looking forward to is the next wave of novel agents that are coming through the pipeline.
Hello, it's my pleasure today to present to you a next wave of novel agents in the management of aggressive B-cell lymphoma during this session. My name is Dlvcl from Memorial Sloan Kettering in New York. As you see, and as already discussed by Dr. Cns and colleagues, there have many agents newly approved in diffuse large B-cell lymphoma, including several CAR T cells, antibody drug conjugate, Selenexor, and tafasitamab in combination with lenalidomide. But there are also a couple of agents in clinical development, such as bispecific antibody, magrolimab, other ADCs, some new targeted therapies, and new immune effector cells. However, for the sake of keeping in time during this meeting, I will really focus on bispecific antibodies. So the first bispecific that was being made available for patients with diffuse large B-cell lymphoma and other lymphoid malignancies was blinatumomab, the BiTE antibody targeting CD19 and CD3. In the early phase 1/2 studies that were reported years ago, there were a response rate ranging from 15 up to 30%. And as you can see, some patients had reached a response that was very prolonged, even 4 years. However, when a multicentric study was carried on to confirm and consolidate this result, what was observed is that given the side effect and the aggressiveness of the disease, many patients unfortunately dropped off study and were not able to complete the 2 cycles of blinatumomab. So the development of this agent right now has been halted, and we have a new class of agent that is being developed in this setting. The mode of action of bispecific is quite straightforward. The antibodies target an antigen, here CD20, and target T cells, develop and deliver signals to T cell, bringing them to the immune synapse and liberating granzyme perforin as well as cytotoxic activity. There is no ex vivo manipulation of T cells, the difference between CAR T cell, and then we can treat patients immediately when they present with progressive disease instead of having to wait for the manufacturing time. Let me review with you a couple of characteristics of the current development of the CD3, CD20 antibodies. As you can see on this slide, there are at least 6 drugs that are in current development, and probably more that I am not aware of. What I would like to outline with you are a couple of characteristics from these drugs. First of all, as you can see here, the format of these drugs may vary. There are bispecifics that are clearly antibodies recognizing 2 different epitopes from each arm of the immunoglobulin molecules. Others are modified, such as eventually targeting twice CD20, being modified in an FC region, having also a different format, such as an IgM for the IgM 2323 drug, which is in current development. So different format called by different names as outlined here. The second characteristic to outline is that different CD3 clones were used for the CD3 recognition domain. And this may result in a different power to activate the T cell that may result in different efficacy, but also different side effects accompanying the activation of T cell. And finally, there are different CD20 recognition domain by the clone that was used, and some of them actually recognize the rituximab epitopes, others not, and eventually may compete with previous rituximab in the body and the tumor of the patient, or with co-administration of this drug. The first one to be developed was mosunetuzumab, and this slide presented several years ago by Dr. Schuster during the ASH meeting represents the objective response rate in patients with different aggressive NHL. As you can see, the overall response rate was 37% and the CR rate of 19.5%. And as reported during this presentation, there were a couple of patients that had failed previous CAR T-cell that actually responded to this drug. This is shown here, where you see the characteristic of the response. Again, the patient after 2 or more lines of therapy had similar rate of response, as well as the patients that were refractory to anti-CD20, or that patients that had received prior autologous stem cell transplant were also well responsive. And while we don't have an updated data regarding the duration of the response, as you can see, some of these patients were maintained for more than 1 year in response. The second antibody developed by the same company is glofitamab, which has the particularity of having, as mentioned already, 2 CD20 recognizing domain. There were a couple of difficulties in the administration of this antibody, resulting in a high rate of CRS with the initial infusion. And the development that was chosen was first to deplete the circulating B cell by administrating an infusion of obinutuzumab 7 days prior to the first infusion of glofitamab, and then use a step-up dosing with escalating dose of glofitamab. The results that were presented recently at ICML by Dr. Carlos Stella in difficult-to-treat patient population are summarized on this slide. As you can see, the response rate was very significant in different subtypes of aggressive lymphoma. The majority of patients actually responded to therapy. And as you see on the curve on the right, while the median follow-up remains short of only 8 months, it seems that the patients that achieve a complete response had a stable result. We obviously need to wait to see further follow-up of this study to better establish the value of this antibody. The events that were observed during this development are shown on this slide. The majority of patients, or substantial proportion of patients, actually experience a cytokine release syndrome, essentially during the first and second administration, and eventually during the third one. But as you can see, the vast majority of these events were grade 1 or 2. There were few grade 3-4 events that were treatment-related, and a few neurological events, if any. Another antibody, which is epcoritamab, was also developed, and the particularity of this antibody is that it is available as a subcutaneous administration. Again, a step-up dosing regimen was developed during the phase 1 escalation, which is described on this slide. The results that were presented by Martin Hutchkins in the ICML meeting represented the study of 46 patients with Dlbcl, with a 3 median prior line of therapies and exposure, obviously, to the usual agents. You can see here the activity in Dlbcl, shown with the waterfall plot on the left, again showing that about half or more of the patients achieved a response, with a substantial number of patients achieving a complete response. And as you can see, despite again a short follow-up, we have some patients that have maintained this complete response now for several months. The adverse events reported were similar, with frequent grade 1 or grade 2 CRS at different doses, very few neurological events, if any, and 1 patient with a tumor lysis syndrome. So on this slide, I summarized all the current response rate for the Dlbcl that were presented in recent years. And as you can see, the overall response rate ranged from 38% with mosunetuzumab to up to 64-76% with glofitamab or epcoritamab, and the CR rate ranged from 20 up to 37 or 48%. So these are really promising agents, but obviously we need to wait until we'll have more follow-up regarding the duration of response and whether these drugs will eventually compete with CAR T-cell, given the response rate that is achieved here, and that may be quite interesting in the setting of unselected patients without having to wait for the manufacturing time of CAR-T. The prospect of developing these antibodies are also broad. As you can see, there are already several trials that combine these different bispecific antibody with standard of care, being in Dlbcl, eventually chemotherapy such as GMOX, or different other agents, and eventually some immunomodulating drugs. There are also the prospect of developing these antibodies with new agents such as Pembrolizumab vedotin, such as immune checkpoint blocker, such as antibodies that will enhance T-cell activation targeting 4-1BB, and other combinations that are possible, which are basically rationally developed in order to increase T-cell activation and prolong the efficacy of this drug. In summary, we have already very efficient drugs in patients with relapse or refractory disease with these bispecific antibodies, and they may represent a new therapeutic options that hopefully will be available for our patients in the near future. They have the potential for salvaging patients after CAR-T failures, as shown already with mosunetuzumab, and several trials are being conducted in this setting. We can also eventually envision that administering bispecific just before CAR-T will eventually boost the CAR-T activity. And as mentioned, there are multiple combinations with chemotherapy or immune interventions that can be envisioned. In the first line of therapy, it's probably quite tempting to continue to develop this antibody, given the fact that the T cells may be less hampered by the previous treatment exposure, and this may result in better efficacy, but we have to make sure that it doesn't result in higher side effect, although some preliminary results presented with mosunetuzumab suggested that it was as well tolerated in the first line setting in Dlbcl as in the second line or later settings. The question is whether how to integrate the bispecific in the current management of Dlbcl. Are we going to use them in combination with R-CHOP in patients with high-risk features? Are we going in slow responding patients to switch chemotherapy for bispecific antibody treatment? And how do we recognize these slow responders? Are we going to use them as single agent in frail patients? I think all these questions are open, and we hope that in the near future, we'll continue to develop clinical trials that will enable us to answer them. I thank you for your attention, and I think we'll take questions at the end of this session. Thank you again.
Well, thank you, Dr. Sal, for that great talk. We do have time for a few questions, so if people have them, please send them in through the app. But I think, I fully see why you decided to focus on bispecifics as really, the next wave of therapy for DLBCL. Although we know there are lots of contenders out there, I think the bispecifics have caught everybody's attention, maybe because of the utility or the benefit that we're seeing with them. But, I'm struck with something that Dr. Weston said in his talk, and that is that when you start to combine new therapies with other drugs like R-CHOP, we need to keep in mind what they might be doing to each other. And you spent some time talking about, can these be combined with chemotherapy? I mean, what is your thought? I mean, you know mainly about efficacy in the single agent setting. What happens when you combine this with chemotherapy? Are you really just going to be suppressing any T-cell response with the chemotherapy? And will it really take large trials to elucidate that and figure that out?
Yes, thank you, Loris. This is a very important question, and I'm sure we don't have the answer. There are some preliminary in vitro data, which all the limitation of this in vitro data of incubating cells together and incubating them with drug, which have been developed by some investigators of company, suggesting that the incubation of the T cell together with the tumor cells, the antibody, and some chemotherapeutic agent has not been major. Very surprisingly, I will say, even the drugs that was used from some of the experiment is bendamustine, which we know is a T cell depleting agent. I think we really have to learn that, and I think this will lead us probably to clearly envision studies where we will monitor carefully what happens to the immune cells in the periphery, and if possible, obtain samples from patients during treatment at the tumor site to see what's going on. I think the complexity of what happens at the tumor site when you deliver chemotherapy, which we know actually does not kill the cell only by breaking DNA, but there is this apoptosis-induced cell death, the mobilization of immune cells here, and how may that be combined with chemotherapy, we don't know. Ultimately, obviously, the ongoing trial, where there is a combination of different antibodies with chemotherapy, will probably provide some answer to that, and that's what we'll look for in the near future.
Just one last quick question. So these will be off-the-shelf products, presumably, and could rival CAR T-cell therapy. Do you think they'll be usable in the community setting, or are these going to have to be used in academic or tertiary care centers based on their toxicity profile that you're seeing?
Well, two quick points. First of all, the toxicity happens only during the first infusion. So you can eventually envision some collaboration between tertiary academic centers and community. The second one is that they are not all equal, and there are differences in terms of toxicity profiles, and it will depend probably of the population of patients you target. So if we are talking about indolent lymphomas, clearly where the current agents are easily manageable in the full ambulatory setting and patients have a good prognosis, I would say we'll go for drugs with a low toxicity profile. If we are talking about relapse, aggressive lymphoma, where there is a limited chance of cure, but probably some more demands to have efficient therapy, we may envision that. And obviously, maybe the step-up dosing will continue to help us to manage that. But at that time being, there are some issues with some of these drugs of being delivered in the community setting.
Perfect. With that, we'll move on to our next talk, which is an update on primary mediastinal B-cell lymphoma by Dr. Kieran Dunleavy from Georgetown University.
Good afternoon. My name is Kieran Dunleavy from Georgetown in Washington, D.C. And today I'm going to discuss primary mediastinal B-cell lymphoma and talk about some results of recent studies and also discuss novel approaches that are in development. Here are my conflicts of interest. So the classification of diffuse large B-cell lymphoma that was based on gene expression profiling over 20 years ago included primary mediastinal B-cell lymphoma, as well as the GCB and ABC subtypes of diffuse large B-cell lymphoma. But since that time, we have gained significant insights into the clinical behavior and molecular biology of PMBCL, and we now recognize it as a unique clinical pathologic entity with distinct mechanisms of oncogenic activation that are different from the GCB and ABC subtypes of Dlbcl. And we think of mediastinal lymphomas as existing on a spectrum of diseases, with NSHL on one end of that spectrum and PMBCL on the other end. And in between these two entities are mediastinal lymphomas that have features in between NSHL and PMBCL. And these have been called mediastinal gray zone lymphomas. NSHL is CD15 and CD30 positive and CD20 negative. PMBCL is CD15 negative, CD20 positive, and usually there's some staining of CD30. And these gray zone lymphomas have immunohistochemistry profiles that are in between these two parent entities. NSHL is characterized by low tumor density and PMBCL by high tumor density. And over recent years, we have improved our understanding of the microenvironment of mediastinal lymphomas. NSHL has sparse tumor cells and a high proportion of cells in the microenvironment are infiltrating T cells, where PD-1 and PD-L1 expression is important. And in PMBCL, there are a lot more tumor cells, but infiltrating T cells that are important in PD-1 and PD-L1 activation are present. So there's a lot of controversy about how best to approach patients with a new diagnosis of primary mediastinal B-cell lymphoma. Historically, the early studies that were led by Italian groups really showed that therapies more intensive than CHOP were associated with superior outcomes. So they retrospectively looked at regimens such as MACOP-B and VACOP-B and compared that to CHOP, and results were better with the former approaches. Then rituximab came along. This, of course, is superior to non-rituximab based therapy in diffuse large B-cell lymphoma. And in primary mediastinal B-cell lymphoma, historical comparisons demonstrated a superiority for rituximab. But at this point in time, R-CHOP, which is the standard in diffuse large B-cell lymphoma, when that has been used in primary mediastinal B-cell lymphoma, as shown in these studies, there's a heavy reliance on mediastinal radiation treatment. Recently, some approaches have not used radiation treatment with more intensive regimens, such as using dose-adjusted Dlbcr or ACVBP and other intensive regimens. These are the results with dose-adjusted Dlbcr. This was the initial study on the left with 53 patients, a larger follow-up study with over 90 patients. And then there was a retrospective study that looked at 150 patients who received the regimen. And the event-free survival in the three studies are pretty similar, as you can see here. So what about different approaches, and how do we compare R-CHOP and more intensive approaches? This is a very interesting study. This study was just published in Blood Advances from the LISA group. They looked at 313 patients with primary mediastinal B-cell lymphoma. These patients were treated in centers in France and Belgium. They received or ACVBP or R-CHOP14 or R-CHOP21. And shown here is the progression-free survival. And you can see that patients who received R-CHOP21 had a significantly inferior PFS compared to patients who received more intensive approaches. It is important to point out here as well that a high proportion of patients in the ACVBP and CHOP14 arms received an autologous stem cell transplantation following induction therapy, even if they were in CR with induction therapy. This is the IEL-SG37 study, and initial results of this were recently presented at the Lugano meeting. This is a study for patients with newly diagnosed primary mediastinal B-cell lymphoma. As shown here, they received rituximab with chemotherapy. And the focus of this study was to look at those patients who had a negative end of therapy PET scan, and they were randomized to either receive involved field radiation treatment to the mediastinum or were observed. Initial results, as I said, were presented recently, and when you look at the CR rate, and on the left here in the first column, you can see that these patients received different therapies, or CHOP21 or CHOP14, MACOP-B, dose-adjusted Dlbcr. The CR rate ranged from 53% to 65%. And I think importantly, if you look at the proportion of patients who had a positive PET scan, 25% of patients at the end of therapy had a double score of 5 who received R-CHOP21, and that was much less for the intensive approaches, as shown here. And when event-free survival was looked at, there was a significantly lower event-free survival for patients who received R-CHOP21 compared to patients who received more intensive regimens. So I think that these initial findings are very interesting. It's a real challenge to approach patients who have a positive end of therapy PET scan at the end of treatment with this disease. Shown here is a patient in her 20s who had received dose-adjusted Dlbcr, had an end of therapy PET scan, which is shown here. And as you can see, the PET is positive with a maximum SUV of 6. She was observed, and 6 weeks later, the PET abnormality had significantly improved, and a subsequent PET was completely negative. So this is a very typical example of a patient who has been successfully treated, is in remission, but has a positive PET at the end of treatment. And this is a real challenge in managing these patients. This was a paper that looked at end of therapy PET scan in primary mediastinal lymphoma by Chris Milani at NCI, and he looked at 83 PETs in total at the end of therapy, and they're shown here according to whether they were negative or positive, negative being Dlvcl 1 to 3, positive being Dlvcl 4 to 5. And what's really interesting here is that if you look at the negative PETs, a negative PET is highly predictive of not having any disease, so that's a very helpful test. But if you look at positive PETs, yes, the patients who had Dlvcl 5 had a very, all of them here actually had disease present, but for those who had Dlvcl 4, just one patient out of 18 had disease present. So that's really important, I think, when we analyze end of therapy PET. This is an interesting slide. It shows the evolution of serial PET imaging in primary mediastinal lymphoma. So these are patients who had positive end of therapy PETs by SUV max scores or by Dlvcl scores. And on the top, you can see patients who were non-progressors. And a lot of these patients, when they continue to have PETs after the end of therapy, they were persistently positive by SUV and by Dlvcl criteria. And then shown here on the bottom are patients who had high SUV maxes and Dlvcl scores who were PET, who actually had disease. And these scores were higher, and the SUV maxes were higher as well compared to the groups on the top. This is a recent study from British Columbia that looked at 159 patients with primary mediastinal lymphoma who were treated in British Columbia over a long period of time. 94% of them received R-CHOP therapy and 44% received mediastinal radiation therapy. They divided patients into a pre-PET and a post-PET era. And shown here are patients who had an end of therapy PET scan, and their time to progression and overall survival is shown. And just like the NCI study, you can see that patients who had a Dlvcl score of 5 tended to do particularly poorly, but those with a Dlvcl score of 4 did it almost equivalently to people who had a Dlvcl score of 1 to 3. So, we're really left with a difficulty in interpreting end of therapy PET in this disease. And I think that there is a real need for more discerning imaging modalities, and also other assessors of response, such as looking at MRD, whether that be end of therapy or interim or both. So what about new approaches to primary mediastinal lymphoma? So a high proportion of these cases have got aberrations of NF-kappa B, JAK-STAT, and PD-L1 and PD-1 as shown here. And there really are a lot of very interesting novel targets in this disease, as well as CD20, where we routinely use rituximab. CD19 is an interesting target. There are now FDA-approved monoclonal antibodies and anti-CD19 CAR T cells, and these have been used in patients with relapse and refractory primary mediastinal lymphoma. Bispecific antibodies are also an interesting strategy. Brentuximab vedotin, which is an antibody drug conjugate against CD30, has been studied, and I'll just show you some data from results in patients with relapsed refractory primary mediastinal B-cell lymphoma. And then, of course, targeting PD-1 and PD-L1 is an interesting strategy, as a significant proportion of these cases have got chromosome 9 aberrations and increased expression of PD-1 and PD-L1. So now for checkpoint inhibition, as I said, a high proportion of the cases have got a 9p24 aberration, as with Hodgkin lymphoma. Pembrolizumab has been tested in relapsed refractory primary mediastinal lymphoma and is FDA approved based on these results shown here, where the overall response rate was over 45%. Nivolumab has been combined with brentuximab for relapsed refractory primary mediastinal. As shown here, the response rate was 73% with a CR rate of 30%. And this was really the basis for the ANHL 1931 study, which is a US cooperative group study, which is being run in the adult cooperative groups as well as in the children's oncology group. It's being led by Lisa Roth at Cornell. And this study is looking at incorporating immune checkpoint inhibitors into the upfront therapy of the disease. So patients with a new diagnosis of primary mediastinal lymphoma are randomized to receive nivolumab with or chemotherapy or chemotherapy without nivolumab. And this is the schema of the study shown here. As I said, anti-CD19 CAR T cells have been studied in this disease. This is an early study of the first approved anti-CD19 CAR T cell. This was led by Jim Kokendorfer at the NCI. And in this early study, you can see that a number of patients with primary mediastinal lymphoma had very good responses to anti-CD19 CAR T cells. And now several of these CAR T cells have been approved for aggressive B-cell lymphomas, and they have incorporated patients with primary mediastinal lymphoma. So in conclusion, the question lingers, what is the optimal regimen for primary mediastinal? But I think that recent data from the ELISA group and the IELSG particularly demonstrate that more intensive approaches are better than approaches such as R-CHOP. And it's really important to develop approaches that obviate the need for mediastinal radiation, as this is a young population and predominantly female. Another question that is really not answered is which end of therapy PET positive patients need radiation treatment. If the PET is negative at the end of therapy, the IELSG study is looking at this. I think that the vast majority of patients do not need to get mediastinal radiation, but we still can't accurately predict which patients who have an end of therapy positive PET scan need radiation. And does this decision depend on the regimen used? And we really need alternative assays to assess response at the end of therapy, as I've discussed. And there are lots of really interesting novel agents in development for this disease. We're looking at emerging results of these different approaches, and some of these agents are being incorporated into upfront studies such as the immune checkpoint inhibitors. So with that, I thank you for your attention, and I'm very happy to answer any questions you may have. Thank you.
So thank you, Kieran, for an excellent talk on what I still think is a very challenging topic for many clinicians. I know in my own center, we often continue to grapple on a patient-by-patient basis. Do we treat this patient with R-CHOP? Is that going to be sufficient if they seem to have low-risk features? Is everybody a candidate for dose-adjusted Dlbcr? Maybe you can just walk us through your standard upfront management. I mean, are you treating all patients the same now? Is it intensive therapy, or how do you distinguish on a patient-by-patient basis?
Yes, I mean, I think with this disease, I treat all patients with intensive therapy. I think going back to the early studies that were led by Zinzani and the Italian groups, I mean, they showed that more intensive approaches in retrospective studies were better than CHOP. But it's a rare disease, and, this is a difficult question. I think that the French groups use RACVBP, and as shown in one of the studies that I showed, I mean, they have very good results with that. So I do think the key to treatment of this disease is a more intensive approach than R-CHOP, and that's what I do. But I totally recognize that it's a rare disease, and unfortunately, there's a lack of randomized studies. So it's a difficult place for us to be emphatic about what to do.
Well, thank you. I think you did a wonderful job presenting the data. And as you say, we don't have large head-to-head trials or really any substantial head-to-head trials. And I think the controversy will likely continue somewhat. Good.
Thanks.
With that, we're going to move on to our next talk, which is going to be given by Dr. Andrew Davies from the University of Southampton. He has another challenging topic, which is really high-grade B-cell lymphomas, double hit, triple hit disease versus the NOS category. And again, another challenge for clinicians.
Hello, I'm Andy Davies from the University of Southampton in the UK, and it's a great pleasure to be here talking to the subject of high-grade B-cell lymphoma and on the subject of double, triple hits and the NOS type. I have a number of disclosures to make you aware of. So the 2016-17 iteration of the WHO criteria gave us a new framework to think about high-grade lymphomas. And we had this new class of high-grade B-cell lymphomas that were associated with a specific set of oncogenic aberrations, and that's translocations involving MYC, BCL2 and BCL6, and a group of B-cell lymphomas that morphologically had similar identity, but lacked those specific genomic aberrations. Other aberrations are allowed, but they lacked those specific translocations. And together, under this umbrella of high-grade B-cell lymphoma, we have a combination of aggressive diseases with common extranodal presentations, a high rate of CNS involvement, and what we consider to be inferior outcomes. So let's just begin with some definitions. Double hit lymphoma, this is what we talk about. And this is a group of high-grade B-cell lymphomas that are characterized by the presence of translocations involving MYC on 18q and BCL2 translocations or BCL6 translocations, or a combination of the two, making it a triple hit. They are primarily de novo diseases, but they can include a spectrum of transformations from follicular lymphoma, and that there are distinct morphologies within this umbrella. So we see a morphology of diffuse large B-cell lymphoma, NOS. We may see a morphology that's intermediate between Dlbcl and Burkitt's, these old-fashioned BCLU, and those with a blastoid morphology. Those that have the specific translocations but a follicular lymphoma morphology don't fall into this category. So as I said, the triple hits are for those who have a MYC rearrangement with BCL2 rearrangements and a BCL6 rearrangement. Then we have this group of high-grade B-cell lymphomas that have similar morphology to I described, but not the Dlbcl NOS morphology. And they have they lack those oncogenic specific aberrations, but they may have extra copies of MYC or patterns of mutations, but they don't have the specific translocations. And then there's a group that's just worth some mentioning in passing of the double expressors. So these are tumors that have diffuse large B-cell lymphoma NOS morphology, but by immunohistochemistry have overexpression of MYC and BCL2 in the absence of translocations. And why do we think that's interesting and important? Well, probably they have an inferior prognosis to Dlbcl that doesn't overexpress those proteins, but perhaps not so bad in terms of prognosis as the true double hits and triple hit lymphomas. I think it's really important to think about this framework in terms of definition. What's really important is that we remember the morphology, and we start with the morphology as our starting point, and we look at B-cell tumors, high-grade B-cell tumors, and we look to see, does it look like Dlbcl NOS? Does it look like Burkitt's? Does it look blastoid? Does it look like it's an intermediate form between Burkitt's and Dlbcl? We look to see the expression of TDT. Those who are TDT positive fall into the lymphoblastic classification. Those who are TDT negative, we then do the MYC analysis, and all of those, whether it be intermediate between Dlbcl and Burkitt's or blastoid or Dlbcl, are all fall into this category of high-grade B-cell lymphoma with MYC and BCL2 translocations. If they look, they don't have the translocation, then they fall into the NOS category. So we see a range of morphological findings, but they're united by this presence of the translocations between the similarity of the translocations. And when we look at the frequency of the translocation high-grade B-cell lymphoma, we recognize that the majority will be double hit involving MYC and BCL2, and that's probably about 60% of tumors. About 20% will have MYC and BCL2 translocations, and about 20% will have triple hit disease. We know that those who have translocations involving BCL2 are much more likely to be of the GCB phenotype, and those with MYC BCL6 translocations are of the ABC phenotype. And if we look at the pattern of mutations, we see that the pattern of mutations is probably intermediate between those that we see in Burkitt's lymphoma and those that are characteristic of the GCB type diffuse large B-cell lymphoma. And that's even the case in those patients who have BCL6 translocations. So what do we do in terms of helping us understand and identify those patients who fall into this group? And should we do FISH testing on everybody who has Dlbcl NOS morphology? Now, I think if we look back at some of the retrospective data, we recognize that there's clear heterogeneity in behavior and there's differences in outcomes. And it may well be because FISH was performed retrospectively in some of these past series. It may well be that FISH was performed because of poor kind of clinical behavior, or FISH may have been performed because of the difficult morphology. So let's think about a population of patients with diffuse large B-cell lymphoma, because they will account for probably 70 to 80% of high-grade B-cell lymphomas. We recognize in Dlbcl about 8% of tumors will have a double hit or a triple hit, and that's probably about 5% who are MYC BCL2 and 1% who are MYC BCL6 or actually triple hit lymphomas. We should do FISH on all on all Dlbcl morphology, because this is really important in terms of guiding prognosis, guiding therapy, and actually the patients ask us very strongly to have this information. And so we would recommend that all patients with Dlbcl have FISH performed for MYC, BCL2 and BCL6. But I do recognize that this is resource intensive and may not be practical in all healthcare settings. So what might you do in order to have a methodology where you're more selective in choosing which patients you select for FISH analysis? And there have been a number of attempts to try and identify this. We may be selecting patients based upon GCB cell of origin, but of course you'll miss some of your MYC BCL6 patients, maybe selecting upon cell of origin and immunohistochemistry, and that provides some reasonable degree of sensitivity and specificity for a positive FISH result. But really, I would encourage us to be able to do this on all patients with Dlbcl morphology, because I think it does really change our approach to the management of these patients. So I'd like to draw your attention to, I think, a really important study that looked at the prognosis of patients with double hit and triple hit lymphoma. And this was from the Lüneburg Consortium, who started off with a large number of patients, over 5,000 patients, of which they were able to draw material and full clinical data sets from 2,400. And this looked at about 264 patients who had MYC rearrangements. The prognosis of those patients who had a single MYC rearrangement, but without a BCL2 or BCL6 translocation, was the same as those that lacked a MYC rearrangement. But the prognosis of those patients with double hit or triple hit lymphoma was inferior to those patients who didn't have a MYC or a MYC translocation or had just a single MYC rearrangement. But actually the prognosis was perhaps less, was perhaps better than we had seen in previous series. Now, we also documented in this study that actually the prognosis of double hit lymphoma, whether it be BCL2 or BCL6 driven, and also triple hit lymphoma, was very similar. So I think this was really important in terms of guiding us. What was also interesting from this study was that patients who had a MYC that was rearranged with a non-immunoglobulin partner did not differ in outcome from those patients without a rearrangement of MYC. So I think it's really important in our strategy that we examine the partner of the MYC rearrangement. And that's really important when we're thinking about our risk-adapted approach. Now, I think our way of thinking about double hit lymphoma and triple hit lymphoma has changed a lot as we have considered not just identification of these patients by FISH analysis, but also by transcriptional profiling. And the so-called double hit signature was derived from the transcription pattern of those patients who had a double hit lymphoma from a group of GCB Dlbcls, and then was applied to a wider spectrum of GCB Dlbcls, and recognized that actually 27% of GCBs turned out to have a double hit signature, and perhaps doubled the number of patients that had already been identified through FISH analysis. So this is a really interesting that we can identify those patients with double hit lymphoma through transcriptional profiling, and a group of patients who have a very similar transcriptional program to those patients who have FISH defined double hit disease but actually lack the aberrations, and that these groups of patients had a poor prognosis, and they had the poor prognosis as those patients who actually had a rearrangement by FISH. Now, for those patients where the rearrangement wasn't identified, but they had a transcriptional signature, in very many cases, next generation sequencing revealed cryptic changes that could be identified involving a pattern of different aberrations. We also in the UK group have identified a similar population of patients that we've defined as molecular high-grade lymphomas that behave in a very similar way and have many of the transcriptional profiles that overlaps with the double hit signature. And interestingly, what we found was a significant therapeutic effect from bortezomib in this group of poor risk patients. So I think my thinking about double hit lymphoma is now really we have those that we recognize who have a FISH aberration, and we have those that have dysregulation of MYC and BCL2 through, although are FISH negative, but have cryptic translocations and other events that result in the same transcriptional phenotype, and therefore the same pattern of disease kinetics and outcome. So I think that our way of thinking about double hit lymphoma and triple hit lymphoma is really very much in its infancy at the moment, and I think we'll see evolution of this classification as we move into the next iteration of the WHO classification. But for the moment, here we are with this FISH-defined group of patients. So let's think about this clinically. Well, we recognize that this group of patients have traditionally been considered to have a poor prognosis, largely presenting in the 6th to 7th decade of life, and as I said, present frequently with extranodal disease sites and with a high risk of CNS involvement. And between double hit and triple hit and BCL2 and BCL6 driven double hit, there probably isn't very much in terms of the way the disease presents clinically. The key treatment themes is that, we don't know what the optimal frontline therapy is for this group of patients. So a clinical trial is recommended, but there are few clinical trials. Of course, these patients have aggressive disease, and it makes them difficult to put in trials because of the time to initiation of therapy. And with disease that's relatively uncommon, it makes the logistics of trial delivery very difficult. So as I say, there's no standard of care, but generally it's considered that R-CHOP is associated with an inferior outcome. We recognize that in Burkitt's lymphoma, which is obviously driven by MYC rearrangement, intensified schedules are associated with a good outcome. So it was clearly natural to want to test those intensified schedules in patients who who have double or triple hit lymphoma. We don't quite know what the role of high-dose chemotherapy consolidation is, and clearly these patients are at higher risk of CNS disease. So first of all, we've got a number of retrospective studies that have looked at intensified therapies. This one of 23 US centers 311 patients demonstrated that perhaps you saw higher response rates with the intensified regimens compared with R-CHOP chemotherapy, particularly dose-adjusted EPOCH. And although there was a progression-free survival advantage using an intensified regimen, there was no overall survival advantage of an intensified regimen over R-CHOP chemotherapy. In a meta-analysis of almost 400 patients from 11 studies, dose-adjusted EPOCH was associated with superior outcomes in terms of progression-free survival, but not a significant improvement in overall survival. In this analysis, there's obviously some difficulty because individual patient data wasn't initially used, but actually from these analyses, it's come out, retrospectively that dose-adjusted EPOCH looks like a highly favorable regimen to use. We do have a prospective study from the NCI that looked in a single-arm study of dose-adjusted EPOCH in patients with single hit MIC rearrangements and double hit rearrangements, and that's demonstrated good event-free survival of 48 months of 73% in those patients treated with dose-adjusted EPOCH with double hit lymphoma. And for this reason, dose-adjusted EPOCH has become pretty much a accepted standard of care for this group of patients. And I know that we may argue about that because there lacks randomized data, but actually for my mind, I think this is the optimal regimen to be using for these patients. Well, you could say, well, R-CHOP was compared with dose-adjusted EPOCH in the Alliance 50303 study, but of course actually then, and there was no difference in outcome, but of course the number of patients with double hit lymphoma was very small indeed in this study, so no conclusion can be drawn about the efficacy of the difference in efficacy from this randomized study. We saw at EHA data presented by Dr. Magnuson from the Flatiron registry of outcomes with patients with double hit lymphoma and triple hit lymphoma treated with R-CHOP and dose-adjusted EPOCH. Now, from this large data set, it looked like the outcomes between R-CHOP and dose-adjusted EPOCH was very similar, with a 4-year overall survival of 49% in those patients with dose-adjusted EPOCH and 54% in those patients with R-CHOP. There was, however, a difference. If you had double hit lymphoma or triple hit lymphoma compared with single MIC rearrangement, you were much more likely to be treated with dose-adjusted EPOCH-R, and for older patients, you are much more likely to be treated with R-CHOP chemotherapy. So I think this is an interesting observation, but actually I think that there's a lot deeper dive that we need to do in examining this before we make any firm conclusions about the optimal frontline regimen for double and triple hit lymphomas. What about limited stage disease? Well, of course, we've got very little data so far on limited stage disease, but it's expanding as we use population-based screening to identify those patients with double and triple hit lymphomas. This is a small series from some academic institutions, which suggested that in early stage disease, the intensified therapeutic regimens probably didn't add much to over conventional R-CHOP chemotherapy, with no improvement in PFS or overall survival. So in terms of the management of limited stage disease, we don't really have any clear recommendation, and there's clearly further work that needs to be done on examining this. What about the importance of CNS prophylaxis? Well, we see probably a higher rate of CNS events in patients with double hit, triple hit lymphoma than we do in Dlbcl NOS. And we see that the attention to the CNS with methotrexate containing prophylaxis is associated with some improvement in overall survival in retrospective studies. But of course, delivering CNS prophylaxis is difficult when you're using the dose-adjusted EPOCH regimen, and it is quite difficult to integrate methotrexate with dose-adjusted EPOCH. And of course, that's an intention to be using intrathecal therapy in these groups of patients, or leaving your CNS prophylaxis with IV methotrexate until the end of induction therapy. And that's a great one for debate. The question is, should we consolidate these patients with high-dose chemotherapy and peripheral blood progenitor cell rescue? The answer to that is probably, if you've given R-CHOP chemotherapy, there's going to be a benefit from induction with high-dose therapy consolidation. But actually, if you've given a more intensified regimen for induction, then there's probably no benefit from high-dose chemotherapy consolidation in first remission. In the setting of relapsed disease, unfortunately, the outcomes have retrospectively been very poor, with conventional reinduction followed by high-dose chemotherapy consolidation. We also recognize that in some small numbers of patients who undergo allogeneic transplantation, if they achieve a second remission, there may be some benefit, but really the numbers of patients that we have data upon is really very limited indeed. What's very interesting is the new data on CAR T cells in double-hit lymphoma. And we can see that the response to patients with double-hit lymphoma to CAR T cells is probably not far off the overall response that we see for a general Dlbcl NOS patient population. And I think this is really interesting because, of course, with CAR T cells, you're offering a non-chemotherapy approach to the management of this disease, and a completely distinct mechanism of action. So I think this is really interesting. And when we see the data from the second-line randomized studies of CAR T cells compared with autologous stem cell transplantation, it'd be really interesting to see how the outcomes were in those patients who had double-hit lymphoma. And we're beginning to see frontline studies in patients who have double-hit lymphoma with high-risk disease, high IPIs, and actually interim positive PET scans where CAR T cells have been given to consolidate responses achieved with R-CHOP chemotherapy when they've been less than adequate, than we had liked them to be. And I think this data is really very interesting, but still very new. And we wait to see further analysis and further recruitment into these studies. So what about clinical trials and what about new agents? Well, there are a number of studies that are looking at various novel agents in combination with dose-adjusted EPOCH, including SYK inhibitors, lenalidomide, venetoclax, and checkpoint inhibitors. So there's plenty of targets for us to be able to examine, as well as using CAR T cells earlier on in the disease. The Dutch HOVON group have done a study prospectively looking at adding lenalidomide to R-CHOP chemotherapy, which is a good solution for particularly for older patients who have double-hit lymphomas. And actually, if you compare their outcomes to some retrospective data, they look actually highly satisfactory. So I think this is a really interesting solution. But of course, the data is single arm and is non-comparative, as is such the problem with such infrequent diseases. So that's double-hit lymphoma. What about the group of high-grade B-cell lymphomas not otherwise specified? This is a small subset that have overlapping morphological findings with double and triple hit lymphomas, and they may carry single MYC rearrangements, or they may carry mutations in MYC or copy number changes, but they lack the double hit or triple hit genetics as we defined. They morphologically are either intermediate between Dlbcl and Burkitt's lymphoma, or they have a blastoid phenotype. Very limited data, very limited about therapeutic information. We have an approach of using the intensified regimens, and I think most people would consider using dose-adjusted EPOCH in this group of patients. There is a suggestion from some retrospective studies that those patients who have high-grade B-cell lymphoma NOS might do better than those who have a MYC rearrangement, but it's based on very small numbers of patients. Finally, double expressors. These are a distinct biomarker in diffuse large B-cell lymphoma NOS. They are not a distinct category. They have been reported to have very poor outcomes in some retrospective series, but we found in our own series that although the outcomes are inferior to those who do not have overexpression of MYC or BCL2, they are not as bad in terms of outcome as those patients who have been retrospectively reported. So I would say to you that R-CHOP chemotherapy remains the standard of care for this group of patients, but there are studies that are ongoing examining novel approaches for this group of patients. So really, just in terms of the take-home message with double-hit lymphoma, it's not a single class. the morphology remains really important. Do FISH in all cases of Dlbcl so that you can identify these groups of patients, but you need to make sure that your laboratory is doing FISH in a clinically relevant time frame so that you can address therapeutic changes based upon the FISH result. I would say, based upon limited data, that dose-adjusted EPOCH is associated with excellent outcomes or much better outcomes in this disease. And for my mind, that's the standard of care. But I would recommend that if you could enroll these patients into clinical trials, and remember to attend to the CNS. Double expressor lymphoma is difficult. Data sets are limited. R-CHOP is still a reasonable approach. For double hit and triple hit lymphoma, conventional second-line therapies are associated with poor outcome. The data with CAR T cells are very promising indeed. The field is not standing still, and I think soon we'll be using more sophisticated and perhaps less resource-intensive approaches to defining poor risk diffuse large B-cell lymphoma through transcriptional analysis and also through NGS. Thank you very much for listening. I look forward to our questions.
Great. Well, thank you, Andy, for that excellent, comprehensive talk on a difficult topic. I think, it's clear that many of us are using dose-adjusted EPOCH-R as frontline therapy for these patients now and those who can tolerate it. It's going to be a real challenge to add novel agents into that backbone because it's already so toxic. With the front runners that we have as novel agents in Dlbcl, I mean, would you predict where the winners might be in terms of what might have added value for double hit, triple hit lymphomas?
I think, Laurie, that's a really good question. I think it's impossible to predict. I think, we've had our fingers burnt in terms of Dlbcl, in terms of predicting winners as well in the past. So I think, as I said in my talk, I do think there are plenty of targets. I think there are some challenges in terms of delivering clinical trials in this group of patients. Of course, what we're seeing is non-comparative studies, which make it even more difficult. What I'd like to see is more collaboration and for us to have some randomized studies, randomized phase 2 studies in this group of patients so that we can identify winners in the future.
Perfect. Thank you. Well, with that, we'll move on. So we're going to close out our session on aggressive B-cell lymphomas with 2 submitted abstracts. And the first will be presented by Dr. Brad Cowell from Washington University, and he'll be presenting an update on the LOTUS-2 trial of loncastuximab tesirine in diffuse large B-cell lymphoma. Brad?
Hi, I'm Brad Cowell, and on behalf of my co-authors, I would like to present our oral presentation entitled LOTUS-2, Follow-up Analysis, Updated Results from a Phase 2 Study of loncastuximab tesirine in relapsed or refractory diffuse large B-cell lymphoma. Here are the author disclosures. Patients with relapsed or refractory diffuse large B-cell lymphoma for whom salvage chemotherapy or stem cell transplant are unsuccessful have a poor prognosis and limited treatment options. Loncastuximab tesirine, which I will refer to as Lonca-T, comprises a humanized anti-CD20 antibody conjugated to a potent pyrrolobenzodiazepine dimer toxin. It is currently being evaluated in patients with relapsed or refractory diffuse large B-cell lymphoma in the phase 2 LOTUS study. LOTUS-2 primary efficacy and safety data after at least 6 months of follow-up were recently published in Lancet Oncology. Here we present updated results after at least 17 months. Enrolled patients were at least age 18 or older, were heavily pretreated, having received 2 or more prior systemic treatments, and they received Lonca-T at 150 micrograms per kilogram every 3 weeks for 2 cycles, followed by 75 micrograms per kilogram every 3 weeks for up to 1 year. And then patients are followed every 12 weeks for up to 3 years. A total of 145 patients were enrolled. As of March 1st, 2021, patients received a mean of 4.6 cycles of Lonca-T. 34.3% of patients who responded had 7 or more cycles administered. 74% of patients experienced a grade 3 or higher treatment emergent adverse event. These were most commonly neutropenia, thrombocytopenia, increased GGT, and anemia. All grade treatment emergent adverse events were considered likely related to the PBD warhead included edema or effusion, skin reactions, nail disorders, and liver enzyme abnormalities. 19% of patients had treatment emergent AEs that led to treatment discontinuations, while these AEs led to a dose delay in 43% of patients. Turning our attention to the efficacy data, the overall response rate was 48% by central review, with 24.8% of patients achieving a complete response and 23.4% of patients achieving a partial response. The median duration of response for the 70 patients who responded was 13.4 months, but this was not reached for patients who achieved a complete remission. More details are seen in the Kaplan-Meier curve on the right. The Kaplan-Meier curves for progression-free survival and overall survival are presented on this slide. The median progression-free survival was 4.9 months, while the overall survival was 9.5 months. Following Lonca-T treatment, 16 patients had CD19-directed CAR T-cell therapy with an investigator-assessed overall response rate of 44%. 11 patients went on to have stem cell transplant consolidation after responding to Lonca-T. Finally, the outcome in patients who had a complete response is shown in the swimmer's plot. 44% of these patients remained in complete remission with no further treatment, but this increased to 61.5% if we exclude those who were censored due to stem cell transplantation. In conclusion, after longer follow-up of patients in LOTUS-2, durable responses with a median of 13.4 months continue to be observed in heavily pretreated patients with relapsed or refractory diffuse large B-cell lymphoma treated with Lonca-T. In addition, no new safety signals were reported. Efficacy and safety continue to be monitored. We would like to thank and acknowledge the participating patients, their families, and all the study sites, co-investigators, and research coordinators. Thank you for listening and for your interest in our presentation, and I would be happy to take any questions.
Great. Thank you, Brad, for this great presentation. I think we have time for a few questions, and maybe you could explain, is this an agent that's meant to be given indefinitely? It seems like the clinical trial had a finite duration of several years, but in the monograph, it's not clear to me whether or not there's a recommended stop time.
So in the phase 2 clinical trial, the dosing was stopped after 1 year, although I can tell you it's very rare that a patient makes it the whole year on therapy. In my experience with the drug, giving it for that long a duration becomes problematic due to cumulative toxicities. And so if you have a patient that's responding, I think anticipating administering 6 to 8 doses is probably more realistic.
So we also heard a lot in the session today about novel therapies for Dlbcl, and of course, this has been a new contender that's emerged and now available for use. Where do you see this lining up in terms of options for patients with Dlbcl? What patient are you going to be using this drug in?
Well, one thing I want to do is correct myself. I called it an anti-CD20 target at the beginning of my talk, which was a total typo. It targets CD19. So I think one of the nice things about this drug is it works immediately. So if you have a patient who comes in with relapse disease and maybe is very symptomatic, maybe they're in a lot of pain, maybe they have chemotherapy refractory disease, and you need to go to something off the shelf that can work immediately, this is a treatment that can kind of get you out of a jam. So I do think if you have someone with aggressive disease who needs a very quick response, this is a very good option to go to.
And how comfortable, given the fact that it does target CD19, would you be using it ahead of CAR T-cell therapy? I know that there's some data that patients went on to receive CAR T-cell therapy subsequently?
Right. So that's the big unknown. Until we get more data, I would generally try to avoid it prior to CAR T-cell therapy and find other ways to bridge patients. It may become clear with time that that is an unfounded fear, but for now, because CAR T has curative potential, you certainly don't want to do anything that would lower your likelihood of achieving that cure for your patient. So I would avoid it for now until we pre-CAR T, until we get more data telling us it's okay to do so.
Great, thank you. With that, I'll hand over to my co-chair, Dr. Sell.
Thank you, Dr. Sen. And I think we are very fortunate to have as a last talk of this session a second poster abstract, which will be presented by Dr. Khan from Pittsburgh regarding the use of glofitamab and the updated result regarding the efficacy of this compound. Dr. Khan?
Hi, everyone. My name is Cyrus Khan. I work at Allegheny Health Network in Pittsburgh, Pennsylvania, and thank you for listening to this presentation and looking at the slides. We'll be presenting the glofitamab step-up dosing and updated safety as well as efficacy data for patients with heavily pretreated relapse refractory non-Hodgkin's lymphoma, and these are the authors. These are the disclosures. I'll keep it on the screen for a minute for all the authors on the study. So as a background, glofitamab is a T-cell engaging bispecific with a novel 2-to-1 format, and in preclinical studies, this format showed that it had greater avidity, potency, as well as combinability with other anti-CD20 IgG antibodies than alternative bispecific formats. As you can see here, this is a 2-to-1 format. So this has been taken forward into various clinical trials. The step-up dosing, in addition to GPT, which means the obinutuzumab pretreatment, then also allowed dose escalation up to 30 milligrams to maximize efficacy as well as mitigating the CRS. So this was important as well. And then we'll be looking at data presented from 2 different dosing cohorts. One was the, of course, step-up dosing with 2.5, 10, and then 16. And then the other cohort went up to almost 30 milligrams from cycle number 2. So we'll be looking at both these cohorts. Now, this was the MP30179 trial. Again, this is an ongoing phase 1 and 2 dose escalation study for relapse refractory non-Hodgkin's lymphoma. So all comers, and we'll see what kind of patients went on it. So as far as the treatment schedule is concerned, you can appreciate that on cycle 1, day -7, 1,000 milligrams of obinutuzumab was given. Cycle 1, day 1, glofitamab at 2.5 milligrams. Cycle 1, day 8, it was 10 milligrams. And then from cycle 2, day 1, up to cycle 12, day 1, so this was for 12 cycles, it was either 16 milligrams or 30 milligrams, depending on which cohort the patient went on to. And then, of course, this is only 12 cycles. There's no continuation. As far as inclusion criteria are concerned, again, they had to just have B-cell non-Hodgkin's lymphoma with expectation of expression of CD20. And again, these are the objectives for safety, tolerability, and as well as pharmacokinetics. Again, this trial did include heavily pretreated patients. As you can see here, median age was 68, range was anywhere from 45 to 85. Median prior lines of therapy were 3 with a wide range, as you can see here. And again, it included a variety of different chemotherapeutic options. Almost all the patients had chemotherapy as well as an anti-CD20 monoclonal antibody. About 21% had an autologous transplant. And then you have some patients receiving CAR T-cell therapy, immunotherapy, as well as a PI3 kinase inhibitor. For refractory patients, you can see about 84% of the patients were refractory to any prior line of therapy, and then about 2/3 were refractory to their most recent prior line of therapy. There's a wide variety of different non-Hodgkin's lymphomas, including Dlbcls, Richter transformation, transformed follicular lymphoma, mantle cell lymphoma, etc. And you can see there was also a cohort of indolent non-Hodgkin's lymphoma, most of them follicular lymphoma. And you can see here about 16 patients received the 16 milligrams dosing, and then about 34 patients had the 30 milligram dosing. Significant responses were seen, as you can see, for the aggressive non-Hodgkin's lymphoma. If you went on to the 30 milligram cohort, almost 2/3 of the patients responded. So if you look below here in the graphical format, about 64.3% of the patients responded. And again, you can see this was higher in the patients who had received the 30 milligram dose, with the 78.6% overall response rate and a 71.4% complete metabolic response. Indolent NHLs, even more responses were seen. As you can see here, all patients were about 79.2% with a high CR as well as partial response rate. Sorry, I forgot to mention that about 80% of the mantle cell lymphoma patients achieved a complete metabolic response. Anti-tumor activity was also seen across a variety of non-Hodgkin's lymphomas, and this is color-coded to see it more clearly. On the left side, you see the aggressive non-Hodgkin's lymphomas. In the green is Dlbcl, the widest variety of patients. And you can see a lot of the patients did respond. And of course, we see that if you even achieved a partial response, it was significant tumor reduction with these patients. Similar story is seen in the indolent lymphoma side. All of them were indolent follicular lymphoma, and you can see here most of the patients did have a response. Again, this is an ongoing trial, so obviously we are looking at long-term data, and median follow-up in blue is the Kaplan-Meier curve for the aggressive non-Hodgkin's lymphoma. Median follow-up is 8.4 months, and you can see the ongoing responses. In the green is the indolent non-Hodgkin's lymphoma. So you can see about in aggressive lymphomas, 13 out of the 16 complete metabolic responders, the response is ongoing, and almost all of the indolent responses are ongoing. And you can see the various timelines of the responses that are continuing. This is a format which gives you an idea in the kinetics of sort of the follow-up as well as the disease progression and the responses. So up above here, you see the 16 milligram cohort in the aggressive lymphoma, and then below down here, you see the 30 milligram cohort. And one can appreciate that a few things. In the blue, you see these are the partial responders, and if you're green, that is the complete response. That even if you have a partial response in the beginning, sometimes you can convert that into a complete response. So that's one trend that was seen. The other trend is, if you are not going to respond, we figure out that pretty early on. In the red, sort of these triangles show non-responders, and especially in the 16 milligram cohort, more of the non-responders. And the 30 milligrams, you do see them. Once again, you figure that out pretty early on. And then if you do respond, it is likely that you will maintain that response longer term. As you can see, these are the patients that are ongoing with a response. If you look on the right side in the indolent non-Hodgkin's lymphoma, you can see the 30 milligram cohort down below, the 16 milligram cohort up above, longer follow-up in the aggressive NHL. So you can see here a lot of these patients are with ongoing treatments. And once again, a similar trend. If you are going to be a non-responder, it's pretty early on. And if you do have a partial response, that can convert into a complete response later on as well. So interesting trends that we can see. As far as safety is concerned, of course, we look at cytokine release syndrome, and these are AEs with an incidence of greater than 10%. In green is grade 1, in blue is grade 2, light blue is grade 3, and sort of this dark square is grade 4. And you can appreciate that most of these toxicities are up to grade 2 or 3, mostly grade 1 in green. Even CRS, there's very minimal amounts of patients with a grade 3 and 4 CRS. Also notice that pyrexia or fever is noted here, but these are separated from the fever from CRS. So the investigators thought that these fevers were unrelated to CRS, but the patient did have a fever, so it's reported here. And everything else is here in this format. This shows you kinetics of the CRS, and you can appreciate here that most of your CRS is going to be in the first cycle. Patient has more disease bulk, and obviously you're expected to produce more of the CRS there. But once again, most of this is grade 1 and 2, as you can look at this in green and dark blue. From cycle 2, obviously the higher dose produces more CRS, but once again, it's mostly grade 1 and 2, as you can appreciate here. Not many patients had grade 3 or 4 CRS, and there were no grade 5 CRS. As far as other adverse reactions are concerned, you can see here treatment-related. About 90% of the patients had some adverse reaction. SAEs were in about half the patients, treatment-related. No fatal SAEs, but you can see not a lot of patients came off trial because of AEs. Only about 2 patients came off the treatments because of adverse events. There was also some correlatory studies, and it was noted that the responses did not depend on the range of CD20 expression level or CD8 T cell levels. As you can see down below here, if you look at the CD20 cells of the total in the tumor area, the range was quite a bit, but in complete metabolic responders, if you're low expression or high expression, the responses were seen. You can appreciate here for patients who did not respond, even they had higher levels and still had problems there too. As far as T cell infiltration is concerned, similar story. Even if you had a complete metabolic response, it was seen all over the place, whether it was low or high, and same thing here. So there was really independence between the 2 factors as far as response is concerned. So in conclusion, again, this step-up dosing updated analysis shows impressive responses, and showing that partial responses can translate into a complete response in a very heavily pretreated population, and these seem to be durable as well as manageable toxicity. And we can go up to 30 milligram dosing, and this is the way to do it in these patients. And we looked at CRS mostly in patients with cycle 1 and cycle 2, and also at managing levels. In the end, we would like to thank all the authors would like to thank all the patients, their families and caregivers, as well as all the investigators, nursing, and all the staff. It's been a difficult few years, and so we appreciate everybody's help. Again, this is sponsored by Roche, and third-party medical assistance has been provided, as you can see.
Well, we are at the end of this session. I think we had a complete overview of the biology of Dlbcl, the new treatment options, the new concepts that need to be discussed, what has been recently approved, what will be developed, and an update on some difficult cases such as primary mediastinal and double hit. I hope you enjoyed being with us this afternoon, and we wish you an excellent continuation of the SOHO meeting, and we hope to see you in person at the next meeting next year, if not before. And I will then thank my co-chair for co-chairing this session, as well as all the organizers for the excellent performance of this meeting. Thank you, and hope to see you soon. Enjoy the rest of the meeting and your weekend.